So before we go into the details of these systems, I want you to understand what reproductive tract infections are. Okay. So you have to realize that, as you know, that so male and female, they have two different reproductive tracts, and any infection that occurs in the reproductive tract, whether it be sexually transmitted or it be not sexually transmitted, it comes under reproductive tract infections. So if we are considering all infections that occur in the reproductive tract, every is a reproductive tract infection. However, sexually transmitted infections are technically a subset of the reproductive tract infections, which includes only those reproductive tract infections that are transmitted by sexual contact. Okay. Usually in women, reproductive tract infections will involve infections of the outer genitals, which is in the perineal area, the vagina, cervix, uterus, tubes, or ovaries. Okay. And in men, it involves, as you know, it will involve infections in the penis, testis, scrotum, or in the prostate. Okay. Now, these include all of whether it be a fungal, viral, or bacterial infection, all will be included under the broad term of reproductive tract infections. Okay. Going ahead, looking at what specifically sexually transmitted diseases are. So these are diseases that are caused by microbes, which are passed on from one individual to another individual, specifically through sexual contact. So while reproductive tract infections are a definition based on the anatomical site where the involvement is, sexually transmitted diseases are infections which are labeled, which are classified according to the mode of transmission. And here the mode of transmission is through sexual contact. What you have to appreciate is that sexually transmitted diseases many a times can also be transmitted by routes other than that of sexual contact. So just that because there is a disease which is a sexually transmitted disease and it has occurred to one person, it does not obviate the fact that it has been transmitted by sexual contact. It is just that it is a disease which is usually transmitted by sexual contact. Okay. So STDs are applicable to only those specific diseases which are transmitted by sexual contact, and you know that among these gonorrhea, syphilis, HIV, hepatitis are some of the commonly concerned diseases that we are. Diseases like human papillomavirus infections, diseases like scabies are also sexually transmitted diseases, but again, those are not diseases that are exclusively transmitted by sexual contact. Okay. So sexually transmitted organisms might also sometimes be transmitted by non-sexual modes of transmission, as we were discussing. Now, since these sexually transmitted diseases are associated with the transmission by sexual contact, there is a lot of stigma and discrimination that is associated with it. So for that same purpose, there was a requirement of a uniform term by which we could understand about these infections and deal with these infections across settings. Okay, so that is why WHO came up with this term, sexually transmitted infections. Now, the term sexually transmitted infections is used because not all of these infections manifest as disease. As you have known from your discussion and concept of health and disease, that disease is only when a person is experiencing overt signs and symptoms as a result of an infection. Okay, and if that person is feeling low because of that signs and symptoms, then that's illness. And because of that, if the person adopts a certain social role, which is known as sickness, right? So not all infections may manifest as disease. For example, a human papillomavirus infection, which is having just genital warts, may not manifest at overt signs and symptoms. Some small condylomas in the perianal region, people might not even notice them. So that is why we are calling them sexually transmitted infections and not sexually transmitted disease, because it's a newer term to indicate infections caused by microbes that are transmitted sexually, but may not always manifest as symptoms and thus do not always result in a disease. Okay. So the fundamental difference between STIs and STDs are while diseases constitute signs and symptoms, infections are just colonization of the host by the pathogen. Okay. So by sexual contact, a pathogen is getting transmitted from one source to another host by that sexual exposure, and that is a sexually transmitted infection. Okay. So sexually transmitted infections is the term that is used by WHO, and that is the standardized term which we will use to refer to all of the sexually transmitted, what we previously used to call as diseases. Okay. So going forward, we will move into the syndromic management of the sexually transmitted infections. Okay. So syndromic management. So what is the purpose of syndromic management? Abhishek or Akanksha, why do we want to do syndromic management?
Sir, because there is scarcity of resources and also to save time to prevent complications.
Okay. So see, when, when we call sexually transmitted infections as a public health problem, the public health problem is multifaceted. Okay. The public health problem is A, because it is affecting a significant number of people. The public health problem is B, because it can potentially affect a large number of other people from these people. Okay. And sexually transmitted infections occur more in people exhibiting certain behaviors, which again predispose them to suffering more from these diseases. Okay. So one of the objectives when management of these diseases are concerned for us is to ensure that we treat these diseases the moment we are able to detect it, so that we can effectively interrupt the transmission. Okay. So the syndromic management of sexually transmitted infections, the main purpose, if we have to look at the main purpose of this is to effectively reduce the transmission of this disease. Because as we were saying that sexually transmitted infections are many a times prevalent more among certain group exhibiting high risk behaviors. Now, when these people exhibiting high risk behaviors, if they have come to the health system and they are seeking health care, then it is giving us a sentinel opportunity to be able to treat the disease in them and prevent the spread of the disease. Now, if we go off a standardized clinical management pathway, then you will see that what we will do is the moment this person talks about maybe a urinary discharge or a genital discharge, or maybe some burning in the urination, we will take that urine sample, and then we will put it for routine examination and culture, and the culture report might take 3, 4, 5 days to come. So the problem with this is twofold. One is that this person may no longer come back after 3, 4, 5 days for us to be able to treat that person. And B, even if that person comes after 4, 5 days to start that person on treatment, by that time this person might have spread that disease to 4, 5 other people in the community. So considering both of these things, a syndromic management of sexually transmitted infections is very, very important, where we are not trying to arrive at a specific uh, uh, and definitive diagnosis, but rather, so what is a syndromic management? A syndrome is basically a cluster of signs and symptoms by which we identify related diseases. Okay. So what is happening is we know that there are 2, 3 probably specific uh, bacterial sexually transmitted infections which are responsive to a group of antibiotics. If we are suspecting that it could be that bacterial infection by the symptom cluster, then we can readily start treatment of that particular disease, and we can avoid any unnecessary delay or lost opportunity of treatment. Okay, thereby effectively reducing the transmission. Is it clear why we need to do syndromic management of sexually transmitted
Yes,
infections?
sir.
Yes, sir.
Fantastic. So going ahead, if we look, so we will see that we are using a particular, so we are using some specific kits, some colored labeled specific kits we are using for the management of certain syndromes. Okay. The first of them is urethral discharge. Okay. So urethral discharge, so any person who is complaining of a urethral discharge, be it pus or be it mucus, be it any discharge. Okay. Whether it is accompanied by pain or burning sensation while passing urine, whether there is increased frequency of urination. And as you know, UTI is usually manifested by a high grade fever. Okay. So any person that is in a reproductive age group or seems to be reproductively active is complaining of a urethral discharge or a pain during burning or increased frequency of urination along with a symptom of fever, we will treat it as a case of probable bacterial urinary infection of the sexual tract, that is a sexually transmitted infection. Okay, it could be gonorrhea, it could be some other sexually transmitted bacterial infection. Okay, so what we will do similarly, cervical discharge. Okay, so in females, if the female is complaining of any cervical discharge, which is the quantity, color, order, we will ask about it, whether there is associated burning, because cervical discharge and urethral discharge can be simultaneously present. Okay, whether there are any complaints by the sexual partners also. So maybe a female is complaining of cervical discharge. We will ask whether the male partner is also having any urethral discharge, or any burning, urination, and those kind of symptoms. Okay. Low backache, we will ask to see whether the cervical infection is going up into the pelvis and is this become PID or not. Okay. So any history we get of urethral discharge, cervical discharge, or painful scrotal swelling, we will think of a bacterial sexually transmitted infection. And the kit that we use for that is a gray kit. So these are the gray kits that come with NACO label on it, and the kit contains azithromycin 1 gram and cefixime 400 milligram. Okay, you see, we give two antibiotics once daily stat. So the best thing about this treatment is it is not long standing. So compliance is not an issue. Okay, you cannot have patients who are lost to mid therapy midway, or they are non-compliant. It's a single dose regimen. You give it right away, supervised then and there, and the person takes it. Okay, usually for upper respiratory tract infections, we'll be giving azithromycin at a dose of 500 milligram. But here the dose of azithromycin is a 1 gram single dose along with cefixime 400 milligram. Okay, both of them are to be taken together. It's a single dose regime for syndromic management, right? So for urethral discharge, cervical discharge, or painful scrotal swelling, what we do is we give kit 1 gray kit containing azithromycin 1 gram and cefixime 400 milligram. Okay. Next, we move on to the genital ulcers. Okay. So genital ulcers broadly, they can be herpetic, they can be non-herpetic. Okay. So we have to look at whether the genital ulcer is single or multiple, painful or painless, whether there is any burning sensation in the genital area, and whether there are enlarged lymph nodes. Okay. A genital ulcer that is accompanied by a enlarged lymph node is most likely a non-herpetic genital ulcer. Okay. And a genital ulcer that is extremely painful, with multiple ulcers and vesicles, and some pus oozing out of that without any lymph node involvement, that is likely a herpetic genital ulcer. Okay. So if it's a non-herpetic genital ulcer, then we usually give a white kit, which is the kit 3. So if it's a non-herpetic genital ulcer, we will get the white kit 3, which contains a single dose of azithromycin tablet 1 gram again, along with a injection benzathine penicillin 1 vial. So again, it's a single dose injection of benzathine penicillin 2.4 million units, which is given. This package, it comes along with a 10 ml syringe and sterile water for injection. So the benzathine penicillin, it will be there. It will have to be diluted with the sterile water for injection. And in the 10 ml disposable syringe, a single dose benzathine penicillin is given IM, deep IM. Along with that, single tablet azithromycin 1 gram. Okay, so that is the dose to be given. Again, you can see syndromic management. No need for long-term treatment. Genital ulcer non-herpetic, no need for long-term treatment. It's a single dose you give then and there, and it will be cured. Okay. If the person is allergic to penicillin, reports allergy to penicillin, then you do not give injection penicillin. Instead, we give the blue kit, which contains 100 milligram of doxycycline. Okay. So we will give the blue kit. Now, doxycycline has to be taken 100 mg twice daily for 15 days. So this here we lose the advantage of treating it with a single dose stat thing. Okay, if the person is allergic to penicillin, then that person will have to take doxycycline twice daily for 15 days. Okay. If the genital ulcer is herpetic, then we use kit 5, which is the red kit, is used for acyclovir. So it contains acyclovir Acyclovir 400 milligram has to be taken thrice daily for 7 days. That is the kit 5, which is for herpetic genital ulcer. Okay. So genital ulcer based on whether there is lymph node enlargement or how painful, whether the vesicles are present, and based on that, and along with burning sensation, so we can classify it as herpetic or non-herpetic. If it's a non-herpetic, we treat it with kit 3, which is a white kit. If allergic to penicillin, we treat it with kit 4, which is a blue kit. If genital ulcer is herpetic, we will treat it with kit 5, which is the red kit containing acyclovir for 7 days, TB dose, right? Other than this, so you can also have vaginal discharge. So if there is vaginal discharge, most likely vaginal discharge occurs due to fungal infections. Okay. So there you ask again about the nature type of discharge, whether there is burning while passing urine or not, genital complaints by sexual partners are there or not. So same history you take. So for vaginal discharge, usually what we will give is tab secnidazole 2 gram odistat and cap fluconazole 150 mg odistat. So that's the green kit, it's the yellow kit. You can again see that it is a single day regime. Okay, it is a single day regime. Okay, where that person will have to take secnidazole and fluconazole. So the main benefit of this syndromic management of STIs is that for most of the situations we have a single dose stat dose which you can give supervised then and there, and that ensures effective treatment and prevention of the transmission of this disease. Okay. For generalized lower abdominal pain, so here probably you're having PID from the sexually transmitted infection. So there is lower abdominal pain can be there, fever, vaginal discharge, menstrual irregularities, lower back, cervical motion tenderness. So this here you are thinking of a bit more aggressive infection which has gone into the pelvis. So this requires longer treatment. Here we give the kit 6, which is the yellow kit. So the kit 6, which is the yellow kit, it contains doxycycline 100 mg BD for 14 days, metronidazole 400 mg BD for 14 days, and tapsefixine again given as OD stat dose. Okay. And finally, for inguinal buboes, you know that this is a important disease, inguinal bubo. So here we treat with the black kit, which is the kit 7, and here we give azithromycin stat dose, and doxycycline here has to go on for 21 days. So grossly, if you want to remember, then you can remember that for urethral discharge, cervical discharge, and painful total swelling, we give the gray kit, which is the kit 1, contains azithromycin and cefixime single dose. Uretrocervix we have covered. We have left vaginal discharge. So if there is vaginal discharge, then we give the kit 2, which is the green kit. It contains secnidazole and fluconazole OD. Okay. Next, we move on to the ulcer. So genetic ulcer, if it's herpetic, we give white kit, kit 3, which contains penicillin and azithromycin, again single dose. If allergic to penicillin, we give kit 4, which is blue, which contains doxycycline azithromycin. And if it's herpetic genital ulcer, then we give kit 5 red, which is acyclovir 400 mg TDS for 7 days. Okay. Lastly, if you're having lower abdominal pain, more disseminating infection, then we have to give kit yellow, which contains cefixime, metronidazole, and doxycycline. Metronidazole and doxycycline being BD for 14 days, and cefixime being Nodistat. And for inguinal bubo, we give kit 7, which is the black kit, azithromycin 1 gram, and doxycycline for 21 days. It is only in the black kit where doxycycline goes on for 21 days. Otherwise, in the yellow kit and in the blue kit, doxycycline is given for 15. Is that all right?
Yes, sir.
Yes, sir.
So when we are doing sexual syndromic management of reproductive or sexually transmitted infections, some very important things that you need to ensure is that it is always pertinent to educate and counsel the client and their sexual partners regarding safe sex practices and the importance of completing treatment. You tell them that if you're not completing treatment, you're not only putting yourself at risk, but you're putting all your partners at risk. And whenever possible, we will always try to treat the partner. We will ask the patient about whether they have multiple partners, if they're a married couple or not. We will try to reach out to the partner, locate the partner, get the partner to also come and get the treatment. Okay. And as long as the treatment is going on, so you have to advise them ideally on sexual abstinence, that for these 7 days, 15 days, you do not indulge in sexual activity to prevent you from co-infection from other diseases, and also to stop transmission of your disease to others. Okay. Or if sexual abstinence is not possible, then at least mandate the use of male condoms to prevent the transmission. Okay. So condoms are also provided where sexual syndromic management of STIs or RTIs are done. Adequate condoms will be provided. You have to educate about the correct and consistent use of condoms. Okay. Whenever a person is coming for STI or RTI treatment, you have to realize that a STI or a RTI is also a risk factor for HIV. So a person who is coming with a STI and RTI, there is a significant probability that that person could have a co-infection with HIV or syphilis. Okay, so it is very, very important that you refer all of these patients who you are treating with any of the kits of STI and RTI. It is pertinent that we refer this patient to ICTC, which is the Integrated Counseling and Testing Center under the National AIDS Control Program. Okay, so all patients who are receiving sexual syndromic management for STIs or RTIs need to be referred to the ICTC. Okay, and whenever we are treating, we need to follow up after 7 days for all of the diseases. Specifically for lower abdominal pain, since the treatment will go on for 14 days, we need to advise for follow-up and 3, 7, and 14 days to ensure whether treatment is going on properly and the treatment is completing properly. And for inguinal bubo, the treatment is going on for 21 days. So for inguinal bubo, you will keep follow-ups at 7, 14, and 21 days. So remember that for all STIs, we keep a follow-up visit at 7 days. For lower abdominal pain, only the treatment is going on for 14 days. So we will keep a follow-up at 3, 7, and 14 days. And for inguinal bubo also, we will keep a follow-up at 7, 14, and 21 days because the treatment is going on for 21 days. Except for that, for all STIs, follow-up will be at 7 days. Okay. If symptoms persist, you need to assess whether it is due to reinfection and advise prompt referral. Okay. And if you are seeing that, okay, this is a person who is having a high risk behavior, who is having multiple sexual partners, or is maybe involved in sexual activity as a part of profession, then it is pertinent that you also immunize them against hepatitis B if they are not already immunized. Okay. So for all people who are having STI, RTI, especially those exhibiting high risk behaviors, you must consider that whether these people have got hepatitis B immunization or not. If they have not got, then you should consider getting them hepatitis B immunization. The regimen of 0, 3, 6 months. So like that, we immunize these under the adult immunization regimen for hepatitis B. Okay. So this is all about syndromic management of STI, RTI. If you have any questions so far,
No, sir.
Abhishek, do I still
Yes,
have
sir.
you? Are you still there,
Yes, sir.
Abhishek? Okay.
Yes.
So next, then we will go on to the next part of our discussion, which is HIV and National AIDS Control Program. Okay, this is a very, very important part of your community medicine syllabus. Uh, so let us go. So as you know, I will not go a lot into this. HIV, the beginning of the transmission was from chimpanzees in South Africa, and initially it was called the simian immunodeficiency virus. The virus transferred to humans and mutated into HIV when humans hunted for meat and came into contact with blood of those chimpanzees. So it is bush meat consumption from which initially the virus came. Mode of action, that it destroys the CD4 cells by attacking the immune system of the body, thus reducing the CD4 count. So steps of infection, acquisition of infection is followed initially by flu-like symptoms, chill, joint pain, muscle pain, sore throat, generalized body ache, some rash, tiredness, weakness. So some generalized constitutional symptoms occur at the acquisition of symptoms. typically known as the seroconversion phase. This is followed by asymptomatic phase where gradually the viral load comes down and goes into a phase of latency, which persists years after years without any symptom. But the virus goes on weakening the immune system, and finally you have the symptomatic phase, which is manifested by your acute immunodeficiency syndrome, which is manifested by weight loss, fever, diarrhea, and various opportunistic infections. So if we consider stage one is generally asymptomatic after the person contracts the infection, but there will be some generalized lymphadenopathy that can occur, okay, as a result of the immune attack by the virus. After this, stage two is manifested by a weight loss, 5 to 10%. There can be some mucocutaneous manifestations like some rash, some peripheral rash can occur over the arms and legs. There can be co-infection with herpes, and there can be recurrent upper respiratory tract infections. Okay, so this is in stage two. In stage three is where gradually AIDS is starting. So you have weight loss of more than 10%. There is unexpected chronic diarrhea and fever, low grade fever and chronic diarrhea, which is not responding to treatment. There can be some associated oral candidiasis or oral hairy leukopenia owing to the immunosuppression and tuberculosis. So tuberculosis is a disease that is intricately linked with the occurrence of HIV, which is why now we have HIV TB collaborative activities, where every person who comes to the RNTCP or to the NTAP program for their TB screening and diagnosis, if they're diagnosed with tuberculosis, they're also screened for HIV. And every person who comes to the ICTC and gets diagnosed with HIV is simultaneously screened for tuberculosis due to the dual burden of these diseases being high. Okay. Last stage is the stage of AIDS, where you know that all of these symptoms, opportunistic infections, infections by cytomegalovirus, some carcinomas, Kaposi sarcoma, lymphoma, and all of these things can occur, which is the stage of acute immunodeficiency syndrome. So all of this you will read in medicine also, and you already know this from the microbiology of HIV. So moving on to the genesis of the National AIDS Control Program and the National AIDS Control Organization. Okay. So in India, initially the National AIDS Control Program, before the program was there, so initially it began as a project funded by the international agencies, where we began with serosurveillance, where so looking for HIV in diverse population groups, specifically among high-risk population groups, among sex workers, among migrant populations, bridge populations, like high-risk populations like female sex workers, male having sex with males, and then some bridge populations like truck drivers, migrant workers. Among those, mainly these serosurveillance activities were initially happening. The National AIDS Control Program got launched in 1992, and since then it has evolved over several stages. And currently we are in the stage 5 or phase 5 of the National AIDS Control Program. So phase 1 of this National AIDS Control Program was on 1992 to 1999, which focused mainly on awareness generation and blood safety. So during this time, the blood transfusion rules, what testing need to be done. So a mandate of testing of HIV in all blood transfusion, all of these were set up. This was during the phase 1, 1992 to 1999. Phase 2 was the next part from 2000 to 2007, which launched direct interventions across prevention, detect, treatment continuum. So this is when treatment of HIV started being available under the national program. The antiretroviral therapy was available for free to HIV infected patients under the national program. So for treatment, detection, and prevention to be available across the country, we needed capacity building of states. So state aid control societies were set up across the country during this phase. 2007 to 2012 is the area of scale up. So here the program is trying to move on from the state level to district to have its presence in every district. This is a period where ART was free and was given to every individual who had a CD4 count of less than 500. So that was the cutoff that we were using previously, that only people with a substantially low CD4 count would be treated with antiretroviral therapy. And finally, you had this phase 4, which was from 2012 to 2017, which was the period of consolidation and enhanced government finding. At the end of this phase, the objectives of the phase 4 were not completed. So phase 4 was extended for another 5 years, and it went on till 2021. And it is from 2021 to 2026 that we are having the phase 5 of the National AIDS Control Program. So moving on, what were the so initially the national AIDS response, if you look from 1885 to 1991, before the beginning of the uh, National AIDS Control Program, what was happening was basically serosurveillance. So targeting groups and having serosurveillance, constitution of a national committee, focus on blood screening and awareness generation. So blood product screening was beginning, and there was a plan for identified vulnerable areas. So there were some specific districts, specific parts of the country having a very high prevalence of HIV in southern states and in the northeast. And the program was being started in those areas to try and address the burden of HIV. Going ahead in NACP Phase 1, so this is when the National AIDS Control Program was established. So under that, we had the National AIDS Control Bureau being set up, the National AIDS Control Organization, and State AIDS Control Societies, formulation of that. And there were implementation of large-scale awareness generation campaigns among people that this is a disease which is a lifelong disease, and it cannot be cured once you get the disease. And at that time, treatment was also not available very well. So it was all about prevention, prevention, and prevention through screening of blood and through safe sexual practices. Okay. And the beginning of licensing of blood banks and banning of professional donors. So people who were professionally donating blood, that was abolished to prevent people trying to hide infections in order to gain money out of donating blood. Okay, so the banning of professional donation was a significant step that was taken in this phase to prevent the transmission of this disease. Okay, and the government realized that it was not possible for the government to reach all of these difficult to reach and high risk populations. The provision for collaboration with non-governmental organizations or community-based organizations for preventive interventions among high-risk groups was also taken. So many a times in community medicine, you're asked about public-private partnership. You have to realize that the AIDS control program is one of the cardinal programs of the government of India, where the scope of public-private partnership was brought in specifically to try and reach this high-risk group and high-risk populations. Okay, along with expansion of the surveillance networks. Next, come to phase 2. Phase 2 is when the program is already up and running. So here the focus is now moving on to, so the blood screening and blood EA was the thing that was happening before. Now we are trying to diagnose the burden of the disease across the country. So there is establishment of the facilities of VCTs. VCTs. So previously these were known as voluntary counseling and testing centers, named as VCTs. And PPTCT. PPTCT is prevention of parent to child transmission of HIV. Okay. So you know that since it is a sexually transmitted disease, a disease that is transmitted through body fluids. So if the mother is pregnant and the mother is having HIV, there is a high chance, almost 20 to 45% chance of the mother transmitting that HIV onto the child. So prevention of transmission of this HIV from the mother to child was very, very important, especially in a situation where antiretroviral therapy was not properly available. Okay. Along with that, there was introduction of antiretroviral therapy. So antiretroviral therapy at that time was very, very expensive, and it was completely out of reach of the common people. So introduction of antiretroviral therapy and establishment of antiretroviral therapy centers from where people could go and get these drugs for free and remain under treatment with regular supply of drugs. Okay. There was a national constitution of a national parliamentarian forum and a national council on AIDS, an adoption of national AIDS prevention and control policy and the national blood policy. Till date, it is the national blood policy that dictates all of the process of blood donation, testing of blood, cross matching, and ensuring that in no way do we transmit infections by the way of blood transfusion. So whenever we have a blood sample, the blood sample is tested. It is tested for HIV, hepatitis B, hepatitis C, malaria, and syphilis. These five tests, these are mandated, which must be done to prevent the transmission of these diseases by way of blood transfusion. Okay. So national blood policy was formulated in this phase in NACP phase 2 to make transfusion of blood safe. Next in NACP phase 3, which was from 2007 to 2012. So here there was scale up of the facilities pan India with development of district based facilities. Okay. And in order to strengthen the parent to child transmission of HIV, this was the phase where mandatory HIV counseling and testing services were included as part of antenatal care services. So NACP was in collaboration with the RMNCH program that was underway. HIV counseling and testing services were integrated with pregnant women. Pregnant women surveillance of HIV among pregnant women is also done to classify districts as high risk or low risk. Okay, so depending on what is the prevalence of HIV among pregnant women, districts are classified as high risk or risk. Okay, so HIV counseling and testing services, which is now routinely done for all pregnant women, it was started at that time. Okay. Other than that, next coming to the NACP phase 4. In the NACP phase 4, the most important thing was the launch of the National HIV/AIDS toll-free helpline, which is 197. 1097, it is the toll-free helpline till date, and a dual elimination of vertical transmission of HIV and syphilis. Okay, so we realized that these are two diseases that have a high co-occurrence and that have a high rate of vertical transmission from the parent to the child. And you know that syphilis congenital transmission can cause various problems in the child. Okay, so dual elimination strategy. Now also when you're referring a person comes from syndromic management of STI, you're referring to ICTC. There is dual testing for VDRL for syphilis and rapid testing for HIV. So the adoption of HIV syphilis joint elimination was done during this phase. Also, certain high risk settings where in prisons where there is a lot of male having sex with males and other kind of problems there, high risk settings. So NACP interventions were launched there. Strategic expansion of the HIV screening through ICTCs and CBSs. The CD4 cutoff level for treatment initiation was shifted to 500 cells per millimeter cube. Okay, and AIDS is the only disease in our country for which we have a dedicated law. Okay, so the HIV/AIDS Prevention and Control Bill was put forth during the NACP phase 4. Okay. In the continuation phase, so NACP did not achieve all of the things that it set out to achieve in the phase 4 from 2012 to 2017. So it continued as the NACP phase 4 extension from 2007 till 2021. So during this period, it was originally approved up to 2020 and then extended to 2021. The main cardinal thing is the passing of the HIV/AIDS Prevention and Control Act. The act was enforced in September 2018. The key provision is to ensure equal rights to treatment and to prohibit discrimination against affected HIV-infected individuals. We'll come in more detail to this act. So the key clinical initiatives during the NACP phase 4 was the test and treat policy of April 2027, which says that it abolished the previous guideline of keeping this to 500 cells per millimeter cube. This was abolished. So at now what started is the moment a person is diagnosed with HIV, irrespective of the CD4 count, the treatment with highly active antiretroviral therapy known as HAART, highly active antiretroviral therapy. It's a three-drug regimen. A highly active antiretroviral therapy started immediately upon diagnosis of HIV. So this was the main one of the very good initiatives that began that has gone a long way in controlling the burden of the disease. So the moment someone is diagnosed, they're put on treatment, irrespective of their CD4 count. It does not matter whether they have symptoms. It does not matter what is their CD4 count. They need to be started on treatment immediately on diagnosis. So that is the test and treat policy. Next, a lot of people who were lost to follow up due to uh, inadequate availability of medications or due to side effects of the previous medications. So there was a dedicated drive to bring back people living with HIV under the aegis of the program and to put them again on highly active antiretroviral therapy. So this was known as the mission Sampark, which wanted to find out people who were lost to follow up and to put them back on treatment, and universal viral load testing. So every time a patient comes to check their to get the next package of ART for drugs for their treatment, so that they are tested for the viral load. So once in every 3 months or 6 months, they're testing for the viral load along with the CD4 count, and that is documented. So the program effectively is looking at not only, okay, we are supplying with ART, but we are also looking at how effective is this ART in actually achieving uh, reduction of viral load as well as improvement of CD4 count. So you know that a viral load has to reduce for people to no longer transmit the HIV infection in sexual contact. So one of the main objectives of antiretroviral therapy, other than obviously protecting this patient from going into AIDS, one of the main objectives of highly active antiretroviral therapy is to prevent transmission. And prevention of transmission can only be achieved with adequate viral load suppression. So from February 28 onwards, 2018 onwards, there is universal viral load testing. And you know, during COVID-19, there were various challenges with respect to the program activities. So during this, the initiatives of multi-month dispensation were taken. Okay, where patients were simultaneously given treatment for 3 months, 6 months to prevent them from having to repeatedly visit the hospital because HIV patients were already immunocompromised. So them getting infection from COVID-19 would have been dangerous. So those initiatives were taken to ensure proper treatment during the period of COVID-19. Now looking at the HIV/AIDS Prevention and Control Act of 2017. So this, as I was saying, this is the only act that is specifically there for one particular communicable disease. Okay. The HIV/AIDS Act 2007, it is basically to prevent discrimination against HIV positive people. Okay. To prevent discrimination in terms of employment opportunities, in terms of educational establishments. So they should have the right to read at all educational institutions, irrespective of their HIV status. Healthcare services. So all kinds of healthcare services they should be receiving. Residing or renting property, standing for public or private office if they want to be in the legislative body or anything, and provision of insurance. So you know that HIV positive people, since they are immunosuppressed, they are prone to get various other co-infections, opportunistic infections where they may fall ill. So it is very, very necessary for them to have access to insurance that protects them from catastrophic out-of-pocket expenditures, like high out-of-pocket expenditure that can potentially land them into poverty. Okay. So for that reason, this act has been put in place to ensure that they have equal opportunities to work, to educate, to healthcare service, to rent, to do all kinds of things, and they do not face any kind of discrimination. Moving on to, if we look now, so now we are having the NACP Phase 5, which started from 2021 and will go on till 2026. So if we look at where we were at the beginning of the NACP Phase 5 in 2021, so the targets, global targets, whatever are there regarding HIV are from the baseline of 2010. Okay. So the global average reduction in new infections has been 31% from the baseline of 2010. But the NACP program has achieved a 48% decline as of before the beginning of NACP Phase 5. And AIDS-related mortality also in India declined by 82%. Both of them are greater than the global average. So thereby showing that the NACP was doing a lot of good things. And while the prevalence of HIV in India is also low at 0.22%. Okay. The main thing is that the 2030 goal, so we are committed to the Sustainable Development Goals of 2030, and other that one of the goals is to end the AIDS epidemic as a public health threat. Okay, so the targets are a 90-90-90 target where 90% we have a 90% decline in HIV infections as well as mortality by 2030, and that is proposed to be achieved by that 90% of those who are HIV infected know that they have HIV, that is, they are diagnosed. 90% of those who are diagnosed, they are put on treatment, and 90% of those who are put on treatment achieve adequate viral suppression. Okay, so for that only we are also monitoring the viral load suppression as of now. Okay, so as of before the beginning of NACP 5, we were standing at 78, 83, and 85. So the NACP 5 basically wants to strengthen the program further to ensure that we are achieving not only 90, 90, 90, but going one step ahead and achieving even more. So if you want to look at the burden of HIV in our country, you will see that it is the southern states of India, mostly in Tamil Nadu and in Andhra, Telangana, in Karnataka, Maharashtra, and parts of Tamil Nadu, southern districts of West Bengal, northeastern states, Manipur, Nagaland, and parts of North India, Bihar, and eastern UP, where you have a high prevalence of HIV. So this is district-wise data. So districts in India are classified into high, moderate, low, or very low, depending on the prevalence of HIV among adults. So if the prevalence of HIV is more than 1% or the population size having like people having HIV is more than 5,000, then that's a high burden district. If it is in the range of 2,500 to 5,000 and adult prevalence is 0.4 to 1%, then it's a moderate prevalence district. If prevalence is 0.2 to 0.4% and its burden is 1,000 to 2,500 people, it's low. And if it's less than 1,000 and you have a adult prevalence of less than 0.2%, then it's a low burden district. So that is the classification of districts according to high, moderate, low, and very low. Now moving on to the goals of the NACP 5. So the NACP 5 was launched in 2020-21 and it is to be there up to 2026. So it has 5 goals. The first goal is to reduce annual new HIV infections by 80%. Second goal is to reduce AIDS-related mortalities by 80%. Third goal is to eliminate vertical transmission of HIV and syphilis. So the goal of dual elimination of HIV and syphilis. Now, if we have to achieve this, so that has to be achieved by the goal 4, which wants to promote universal access to quality STI RTI services to at-risk and vulnerable populations. So the syndromic management of STI RTI along with the availability of highly active antiretroviral therapy comes under this goal. And goal 5 is to eliminate all stigma and discrimination associated with HIV/AIDS. Okay, so this is very, very important for you. These 5 goals you must remember. First goal is to reduce all new infections by 80%. Second is to reduce AIDS-related mortalities by 80%. Third is to eliminate vertical transmission of HIV and syphilis. Fourth is to promote universal access to quality STI/RTI services to at-risk and vulnerable populations. And fifth is to eliminate HIV/AIDS related stigma and discrimination. Okay. So going ahead, how to meet this? So these goals and strategies, they were kept with the 2030 mandate in mind, where we have to reduce it by 90% by 2030. So under these goals, some specific objectives are there in NACP Phase 5. So the idea is that 95% of people who are most at risk of acquiring HIV infection use comprehensive prevention. Okay, so this is compliance with HIV preventive techniques among 95% of the high risk population. And then 95% of HIV positive people know their status. 95% of those who know their status are on treatment, and 95% of those who are on treatment have achieved suppressed viral load. So if you look at the global targets of 90-90-90, these are the global targets. But the Indian target, as far as the NACP Phase 5 is concerned, is 95, 95, 95. 95% of infected know their status, that is, they're diagnosed. 95% of those who are diagnosed are put on treatment, and 95% of those who are on treatment have achieved suppressed viral load. Okay, so this is about the people who are infected. The first objective is about people who are at risk. So among them, we want 95% compliance with respect to the HIV preventive uh, uh, behaviors that they need to take. Okay. And as far as the infected are concerned, we want 95% to be diagnosed, 95% to be treated, and 95% to achieve viral suppression. Okay. Next, moving on to prevention of parent to child transmission. So 95% of pregnant and breastfeeding women living with HIV should have suppressed viral load towards elimination of vertical transmission of HIV. So the objective is to achieve a zero vertical transmission of HIV from parent to child. Okay, and that can only be achieved if 95% of pregnant and breastfeeding women living with HIV have suppressed viral suppression. So they have adequate viral suppression. Okay, and less than 10% of people living with HIV and key populations experience stigma and discrimination. So stigma and discrimination, this is in line with the goal 5. The objective 4 is wanting to reduce. So these are all about generally about HIV prevention and control. There are two more objectives for STI and RTI, which is a universal access to quality STI RTI services for at-risk and vulnerable populations. So the syndromic management of STI RTI services should be present at all centers, and attainment of elimination of vertical transmission of syphilis. So this is the dual elimination target of syphilis and HIV. So if you look at what are the various services that are to be available at various centers. So if you look at the sub center is a screening center. Starting from below, the sub center is supposed to be a screening center. So there will be the whole blood finger prick test by a rapid kit, and a HIV screening test should be available at the level of the sub center. Moving on, coming to the Ayushman Arogya Mandir, uh, coming to the health and wellness center, the health and wellness center PHCs, the 24/7 PHCs or the health and wellness center PHCs. So they will have standalone integrated counseling and testing centers or facility integrated counseling and testing centers. Okay. The services that will be available here will be HIV screening, prevention of parent to child transmission, HIV TB collaborative activities, and syndromic management of sexually transmitted infections. Okay. So at the level of sub-center, treatment won't be available, but at the level of the sub-center, the HIV screening test should be available. Going up at the level of primary health centers, they can be standalone ICTC or they can be facility integrated ICTCs, where there will be HIV screening, parent to child transmission prevention, HIV TB collaborative activities, and sexually transmitted infection. Okay. The district and community health centers will also have ICTCs. Along with that, they can have ART link or ART blood storage center. So there, antiretroviral therapy will be available. So at the level of community health centers or sub-district centers, the antiretroviral therapy should be available from them. Okay. Going to district hospitals. So district hospitals will have ART centers. They will have blood banks. So the blood policy has to be fulfilled, and all of the additional services will also be there along with counseling services. Okay. And medical colleges, they will have centers for excellence in HIV care and pediatric centers for excellence for HIV care. Okay. So all of the and every service that is there will be present in those. Okay. So this is what service should be present. What you should know for your is that at the level of sub-center, the screening facilities will be there. At the level of primary health center, screening along with HIV TB collaborative screening, syndromic management of sexually transmitted infections, and parent to child transmission prevention. That is nevirapine prophylaxis for children. And and prevention of parent to child transmission through antenatal screening and putting them on the necessary treatment. So that availability should be there at the level of primary health center. ART centers will be available from sub-district or community health centers and above. District and medical colleges, there every facility will be there with respect to the National AIDS Control Program. Okay. So moving on, if we look at who are the priority populations for the uh, National AIDS Control Program, so you know that infants and children, specifically infants and children born to HIV positive mothers, so they are priority populations. Next, adolescents. So adolescents, you know that age group 10 to 19 years, they will have various sexual explorations and they do not have ready access to contraception. So there can be transmission. So under in collaboration with the Rashtriya Kishore Shastra Karyakram, which is the RKSK, which is the dedicated program for adolescents, there will be screening services that will be available for the adolescents also at the RKSK clinics. Okay. So, but remember that for testing adolescents, informed consent of the parent or the guardian is required if they're less than 18 years old. Okay. Next, pregnant and breastfeeding women. So, pregnant and breastfeeding women, if they're living with HIV, the risk of transmission is 20 to 45% from the mother to the child. Okay. So, priority screening of all pregnant women for HIV, very, very essential. Healthcare workers, occupationally, they can be exposed. Occupational exposure to needle stick, to splash of body fluids, needle stick injuries, all of that can happen. So healthcare workers are a priority population. Emergency settings, similarly, trauma, uh, again, blood, yes, splash of body fluids or blood. So those are priority settings of infection prevention and control. Moving on, patients living with TB or Kala-Azar. Okay, both of those are, there are TB, HIV is very prevalent. Also, patients having Kala-Azar are especially vulnerable to develop HIV. So both of these are high risk groups and they need to be screened for HIV. Any person attending STI or RTI clinic and seeking treatment, so they need to be screened for HIV. Sexual partners and spouses of people living with HIV, they need to be also screened for HIV at regular intervals. Nextly, high risk groups. So female sex workers, male having sex with males, injectable drug users. Okay. So these are high risk groups for um, sexually transmitted infections and HIV. Breach populations. So the migrants and the truckers, these are known as breach populations because mostly what is happening is when they're migrating, they're leaving behind their family or their partners. Truckers also, when they're migrating, when they're driving trucks over long distances, they're leaving behind their partners or their wives. And then they will be the ones who will many a times be involved in injectable drug use or in male having sex with male, or they will seek services from female sex workers. So these two are considered breach populations, migrants and truckers, and high-risk groups, which is female sex workers, male having sex with male, injectable drug users, and transgenders. Nextly, prison inmates and persons who have undergone sexual assault. Okay. So all of these are priority populations for counseling and testing services under the National AIDS Control Program. Okay. Any questions so far?
No,
Do I
sir.
have you? Do I have you? Are you understanding? Are we all right?
Yes,
Yes,
sir.
sir.
Am I going too fast or is it okay?
That's okay.
Okay. Okay. So moving on, we will look at the testing algorithm. Okay. So we use various testing algorithms. There are broadly 4 testing algorithms that are used. The first one is the testing algorithm that we use for blood bank. So there usually for blood bank, while we are screening blood for HIV, it is mandated that the test for HIV has to be ELISA. It cannot be a rapid kit. It has to be HIV. It has to be ELISA. Okay. So upon ELISA, you know, ELISA is a confirmatory test with a high sensitivity as well as specificity. So if ELISA is negative, you simply report negative, and if the blood is not having infections of the other four diseases, then it can be readily used for transfusion. If the ELISA report is positive, then that blood has to be destroyed as per guidelines, and it has to be referred to the ICTC for confirmation. Okay, it has to be referred to the ICTC for confirmation. And that person who has donated has to be contacted, and the necessary protocol that is done has to be done for that person. Okay, so for blood we use a single test strategy, which is the ELISA that is done in a single test report. If it's negative, can be used. If it's positive, it needs to be tried. That is the strategy 1. Okay, next, for surveillance we use the strategy 2A. So where 2 rapid kits are done, so and they are done sequentially. Just wait a second. Wrong one. Just let me stop sharing one. This is the wrong one. Give me 1 second. Hmm. Okay. Screen is visible, right? Screen is
Yes,
visible.
sir.
Okay. So what we use, so for blood we use this strategy 1, which is a single test ELISA. For surveillance we use strategy 2A. So strategy 2A involves 2 rapid kits that will be used. Okay. So we no longer do ELISA. 2 rapid kits are used, and they are used in sequence. So first 1 rapid kit will be used. If that rapid kit is negative, we report negative. Okay. If the rapid kit is positive, then you subject to the second rapid kit. Okay. If both are positive, then only we report positive. If the second is negative, we report negative. Okay. You have to realize that the logic behind this is surveillance is being done among people who are not having symptoms, or they are also many a times not having high risk behaviors. Okay, so surveillance, suppose you are doing it among pregnant women, among people coming from STIs. So we are doing surveillance. So when we are doing surveillance, we will use 2 rapid kits. First test comes negative, it's a negative. First test, even if it comes positive, we subject it to second test. If both first and second test are positive, only then we report it as positive and we refer to the ICTC. If the second test is negative, then we report negative. Okay. So this is the algorithm for surveillance, which is the strategy 2A, using 2 rapid kits. Next is the algorithm that we used for symptomatic individuals. So these are symptomatic individuals who have come and you are suspecting HIV. So the suspicion is high. Okay. So here we will use usually 3 kits. Okay. So the first kit, if it comes negative, then we report negative. The first kit, if it reports positive, we subject to the second kit. If the second kit is also positive, then we subject it to the third kit. If all 3 kits are positive, then you report positive. and you proceed for post-test counseling. And you say that the person is infected and the person has to be put on highly active antiretroviral therapy. If the first kit is positive and the second kit comes negative, then also we subject the person to the third kit. Now we can have three scenarios. We can have a scenario where two kits are positive and one kit is negative. That is where first and second kit were positive and third kit came negative. And where first and second kit came positive, but third kit came positive. So if two kits are positive and one kit is negative, we label that as an indeterminate test result. And if two kits are negative, we also report that as negative. So if the first kit itself is negative, or if any two kits give a negative result, then we treat that as a negative. If all three are positive, we treat that as a positive. If two are positive and one is negative, then we treat that as an indeterminate result. So if we have an indeterminate result, then testing should be repeated on a second sample taken after 14 to 28 days. This is keeping in mind the window period. Okay. So if two tests are positive and one is negative, then we should repeat a second sample after 14 to 28. If on the repeat sample also it continues to be indeterminate, then we have to take the sample for a Western blot or a polymerase chain reaction, wherever it is possible. Okay, is this clear? This is very, very important. Is this clear to all of you? So for diagnosis and testing of symptomatic individuals, we will use strategy 2B, where we use three kits or three tests, where the three tests are either using three different antigens or they're using three different principles. And the tests are done in a sequential basis. First test is done. If the first test is negative, you report negative. If the first test is positive, you subject to the second test. If the second test is positive or negative, you subject again to the third test. So if the first test comes positive, you will subject to the second and third test, irrespective of what is the result of the second test. Okay. If it comes positive in all three tests, you report positive and start with post-test counseling. If the report is positive on two tests, negative on the third or the second, then we report that as indeterminate. We go for repeat testing after 14 to 28 days. And if the test is negative after the first positive, if it is negative in both second and third, then we report it as negative. Okay, is this clear with all of you?
Yes, sir.
You must remember this diagnostic and testing algorithm. This can be asked. Okay, that what is the algorithm for diagnosing and testing of a symptomatic individual? Okay, the previous one was for surveillance, this one was for blood, and this is for testing and diagnosis of symptomatic individuals. We have another strategy which is for testing and diagnosis of asymptomatic individuals. Okay, if we are having asymptomatic individuals, again just like the previous one, we will do three kit tests. If the first one is negative, we will report negative. If the first one is positive, irrespective of the second test, we will do the third test also. So at the end of the second and the third test, if all three are positive, just like in the previous one, we will report positive and proceed with post-test counseling. Okay. And here also, just like with the previous one, if any two are positive and the third is negative, we will consider it as indeterminate and we will ask again to come back for repeat test after 14 to 28 days. If one test is positive and two tests are negative, like the previous one. Then it will depend on whether it is a high risk category or a low risk category. You're finding a pregnant woman who has a previous child where she probably was HIV negative. He only has one partner and she is having this A1 positive, A2, A3 negative. You realize it's no risk. You can report negative. You have a female sex worker or a male having sex with male has come to you with without any symptoms but has come with A1 plus, A2 minus, A3 minus. Coming from a high risk group, you consider indeterminate, you advise for a repeat testing after 14 to 28 days. Okay. So the only difference here from the previous algorithm is in this part, where here we were definitely reporting negative, but here we have to consider the risk category. And based on that, we will consider whether to report negative or to recall back for another testing. So that is the strategy 3, the diagnostic algorithm for asymptomatic. Okay. And the first test has to be a test which has a high sensitivity. The second and the third tests are tests which have high specificity. Okay. So if you have had your classes about sensitivity and specificity, and you know how what happens to specificity when two tests are done together, and what happens to sensitivity when tests are done sequentially, you will understand why the first test has to be highly sensitive and the second and the third test have to be highly specific. Okay. So otherwise, simply you realize that the first test we are using it just like the screening. So it has to be highly sensitive because if it is negative, we are reporting negative. So we do not want any false negatives, whereas we can have false positives. So we want the first test to be having high sensitivity. Going on to the second and third test, we are labeling this person as diseased. So that's those two are like the diagnostic tests. Okay. So there it is very, very essential that we do not have false positives. False negatives we are already sure from our previous exclusion. Okay. So here we are more concerned about false positives. That is why here we will consider test assays which have a high specificity. Okay. Is this clear? So far,
Yes, sir.
are the diagnostic algorithms clear? The
Yes, sir.
diagnostic algorithms
Yes,
are very,
sir.
very important. Please ensure that you do not make any mistake with respect to these. Okay. Now moving forward to prevention of parent to child transmission. Okay. So what is parent to child transmission? So you know that since HIV is transmitted from by the body fluids, and it being a virus, it can readily cross the placental barrier. And also during the process of delivery, the baby will be exposed to various maternal fluids. So by that also transmission can occur. And after delivery also during breastfeeding, the baby can be transmitted the disease from the breast milk. Okay. So parent to child transmission of HIV can occur intranatally. It can occur uh, antenatally while the mother is conceiving the baby. It can occur antenatally. It can occur intranatally during the process of delivery, and it can occur postnatally by the process of breastfeeding. Okay. So parent to child transmission prevention aims to address all these three aspects and not any one. So antenatal, intranatal, and postnatally, we have to ensure that the transmission does not occur. Okay. So for that, there are multiple things that are necessary, starting from counseling and testing all pregnant women for HIV as soon as possible. Okay. And then educated the HIV positive mother about pre-care and ART treatment. So highly active antiretroviral therapy to achieve viral load suppression to ensure that the mother does not end up transmitting HIV to the baby. Okay, so educating the mother about pre-care and antiretroviral therapy. Third is planning elective cesarean section from the very beginning During normal vaginal delivery, if episiotomy has to be done, then the baby's exposure to the maternal blood and body fluids is much higher. So, elective cesarean section is always advisable for HIV positive mothers. Okay. Next, prenatal, antenatal, and postnatal ART administration of HIV mother. So, uh, administration to prevent antenatal transmission, natal administration to prevent intranatal transmission, and postnatal administration to prevent transmission via breastfeeding. Okay. And next, so it was previously it was zidovudine based therapy. Now it is nevirapine based therapy. I will discuss in detail in later on. And what happens, the baby's gut, the gut epithelial barrier is immature to handle any other food than breast milk in the first 6 months. So if the baby is not being exclusively breastfed, if the baby is being given feed other than breastfeed along with breast milk, then what will happen is anything other than breast milk is causes a lot of inflammation in the gut of the baby. As a result of the inflammation, there will be breakage in the epithelial integrity of the baby's gut. And along with that, so if the baby is getting some non-breast milk feed in the first 6 months, then by virtue of that other food, there will be gut inflammation and breach of the epithelial integrity. And if there is breast milk that is going at that time from the HIV positive mother, the chances of infection from the breast milk are much, much higher. So mixed feeding is a strict no for all HIV positive mothers. Advisable is to put the mother on highly active antiretroviral therapy and ensure exclusive breastfeeding for 6 months. If exclusive breastfeeding is not possible, then the baby should be put on exclusive replacement feeding. The baby cannot be put on a mixed feeding diet where the baby is getting both breast milk and other feed. Okay, either it has to be exclusive breastfeeding or it has to be exclusive replacement feeding, right? So moving on to the programmatic goal of parent to child transmission. The vision is to keep all women and children alive and free from HIV, and the goal is to work towards elimination of pediatric HIV and to improve maternal, newborn, and childhood survival in the context of HIV infection. Okay, so the objectives of PPTCT are to detect more than 80% of HIV infected pregnant women in India, to provide access to comprehensive PPTCT services to more than 90% of the detected pregnant women, to provide access to early infant diagnosis to more than 90% of HIV exposed infants. So, all infants who are born to HIV positive mothers need to be screened for HIV according to an algorithm, which we will discuss later on. And 90% of HIV exposed infants should have access to that early infant diagnosis. And if they are diagnosed, it is very, very essential to ensure access to antiretroviral drugs as prophylaxis, or if they're diagnosed with HIV, then antiretroviral therapy to 100% of HIV exposed infants. Okay. And to ensure 95% compliance with HIV, ART and HIV infected pregnant women and ARV or ART in exposed children, in order to high compliance of ART to prevent the transmission from parent to child, and high access to early infant diagnosis to get the disease diagnosed if transmission has occurred, and to put on highly active antiretroviral therapy as early as possible, and to ensure that all infants who are uh, infants of HIV positive mothers are either on prophylactic antiretroviral therapy if they are negative, and if they are positive, they are on highly active antiretroviral therapy. Okay. So, you know that now with highly active antiretroviral therapy, HIV affected individuals can lead a near normal life for 35, 40 years. Okay. So, it is very, very essential that they be put on these treatments to prevent disabilities and them suffering from AIDS. Okay. So the essential package of services under PPTCT, so there are many things that are provided. starting from routine HIV counseling and testing services to all pregnant women. We were saying that this was initiated in the NACP Phase V. Ensure involvement of spouse and other family members and move from an NC-centric to a family-centric approach. Provision of lifelong free ART. So the current regimen is of tenofovir, emtricitabine, and efavirenz. So ART to all pregnant and breastfeeding HIV infected women, regardless of CD4 count and clinical institutional deliveries and planning of elective cesarean section. Provision of care for associated conditions. So if there is any TB, opportunistic infection, STIs or RTIs, nutritional counseling and psychosocial support for HIV infected women. Provide counseling and support for initiation of exclusive breastfeeding. So either it has to be exclusive breastfeeding or exclusive replacement feeding. ARV prophylaxis to infants from birth up to 6 months. So at least 6 months of nevirapine prophylactic therapy needs to be given to all infants from birth up to 6 months. Integrate follow-up of HIV exposed infants with routine healthcare services, including immunization. Okay, and ensure initiation of cotrimoxazole prophylactic therapy and early infant diagnosis using HIV DNA PCR at 6 weeks of age. So we will discuss the diagnostic algorithm later on and to strengthen community follow-up and outreach through local community support. So you can see it is a very comprehensive package of prevention of parent to child transmission. So starting from counseling to a family centric approach to a provision of lifelong free ART, institutional delivery, treatment of associated conditions, counseling, psychosocial support, breastfeeding support, prophylactic ARV, early infant diagnosis, cotrimoxazole preventive therapy, and follow up along with community outreach. Okay, so there's a logical sequence to that to the entire package. So there are primarily four prongs of the parent to child transmission. The first prong being primary prevention of HIV. The second prong being prevention of unintended pregnancies, where pregnant mothers, if they know where women of reproductive age group, if they know that they are HIV positive and they do not want to have a baby, they do not end up becoming pregnant in an unintended way. Prevention of maternal to child transmission is the third thing, and prong four is care, treatment, and support, which is through provision of ART and through prophylaxis. Okay, so the primary prevention of HIV is through the you know through the activities for the general population and also for the adolescents, that is done through the RKSK. The prong two, which is prevention of unintended pregnancies, that is for HIV positive non-pregnant family planning counseling in ICTC, more importantly at ART centers. So HIV positive women, if they are not willing to have children, they should be counseled on ensuring that. Prevention of maternal to child transmission for all HIV positive pregnant women by ART, putting them on ART, and care and support and treatment for HIV positive mother and children by early infant diagnosis, cotrimoxazole preventive therapy, prophylactic therapy, or highly active antiretroviral therapy the moment they are diagnosed. So these are the four prongs of the parent to child transmission, prevention of parent to child transmission. So what is done is again looking at that. So pregnant women and breastfeeding women, they need to be put on lifelong ART. So CD4 needs to be assessed, but ART has no relation with CD4, and ART initiation should be done only at the ART centers. Okay. As far as HIV exposed infants are concerned, exclusive breastfeeding for the first 6 months, along with daily nevirapine for minimum 6 weeks, or maximum if maternal ART started late. If breastfeeding is not done, then they have to be put for exclusive replacement feedings with 6 weeks of nevirapine. Okay. If the mother was started on ART late, then nevirapine prophylaxis has to go on for up to 6 months. Okay. And then early infant diagnosis through testing at 6 weeks, at 6 months, 6 weeks to 6 months, at 12 months, and finally at final infant diagnosis at 18 months. Okay. So this is the testing regimen. Test will be done at 6 weeks, at 6 months, at 12 months, and again at 18 months. Okay. Now, there is no indication for continued breastfeeding in women living with HIV. So the breastfeeding will be done for the 6 months, and after that, breastfeeding can need not be continued if other methods of feeding are readily available. So here you have to realize that our guidelines of NACP differ from the global guidelines. If you look at the guidelines of CDC, or if you look at the guidelines of the European Council, you will see that they advise that if a pregnant woman is having HIV, then she should not breastfeed. Okay, but you will realize that these are guidelines in countries where alternate feeds for children are readily available and people belong to a socioeconomic status where they can afford the replacement feeds. Okay, but in a country like India, where in resource poor settings, where mostly the HIV suffering people will also come from a poor socioeconomic background, there it is not sustainable for them to go entirely for a replacement feeding in most cases. So keeping in mind India's socio-demographic condition and the fact that with highly active antiretroviral therapy, the chances of HIV transmission in breastfeeding is less than 1%. So by that, uh, with that data and keeping in mind the India socioeconomic context, in India the advice is that if exclusive breastfeeding is possible, then the HIV exposed infant should be put on exclusive breastfeeding. If exclusive breastfeeding is not possible, then only they need to be put on exclusive replacement feeding. This is how the guideline differs from the global guidelines. Moving ahead, so if we look at the flow, so the moment a woman comes for antenatal checkup, the HIV status has to be checked as part of the universal AMC package. So a whole blood finger prick test will be done. So if that is non-reactive, so normal post-test counseling should follow up involving that what she needs to ensure in order that she does not remain at risk of contacting HIV in future. If the woman is a known HIV infected receiving ART, then she will continue to receive ART. If the woman is a newly diagnosed, she will be linked to the ART center from where ART will be initiated irrespective of the CD4 count or the clinical. The preferred regimen is the TDF, GTC, EVFP regimen along with follow-up for institutional delivery. Okay, and the mother will continue ART after delivery, postpartum breastfeeding, and lifelong. For the infant will be provided daily nevirapine from birth up to 6 weeks. The infant will be linked to the early infant diagnosis services, where there will be a direct blood spot test at 6 weeks. If the infant is positive at 6 weeks, the infant will also be linked to ART center for whole blood test, and then the infant will be started for pediatric ART. The confirmation of HIV diagnosis is done at 18 months by antibody test. Okay, so we will look into the algorithm in detail going forward. So the 50-city interventions on pregnant women continue ART lifelong for pregnant women newly detected HIV positive. We have already discussed this. So going ahead, if you just look at this, I will just zoom it a little bit. So this is for uh, infants which are less than 6 months. So what needs to be done is collect and send a dried blood spot test that is to be done at less than 6 months age, and with that blood DNA PCR will be done. Okay, so till the logic behind this is that till the baby grows on, initially there can be maternal antibodies which will be present normally in the baby. So we cannot test for the antibodies initially. Initially, for the test at 6 weeks, 6 months, and 12 months, the test that has to be done is a PCR for HIV DNA using a dried blood spot. Okay, only at 18 months will the test be done for, like we saw the rapid three test algorithm that we decided that will be done, and that will be done for antibody, because maternal antibodies, even if they were present, they will not stay for that long. Okay. But before that, the tests at 6 weeks, 6 months, and at 12 months will be dried blood spot tests done by HIV-1 DNA PCR. Okay. So this is what we wanted to discuss here. Going ahead, looking at the nevirapine prophylaxis dosing. So depending on the birth weight of the infant, if the birth weight is less than 2 kg, then nevirapine dosing will be 2 mg per kg once daily. If the birth weight is 2 kg to 2.5 kg, it will be 10 milligram once daily. And if the birth weight is more, then it will be 15 mg. So it is available as a syrup with 10 mg per ml. So if the birth weight is 2 to 2.5 kg, 1 ml will be given. If the birth weight is 2.5 kg or more, 1.5 ml will be given once daily. Okay. So that is all about parent to child transmission. If you have any question. So have you understood the initiatives that are there under parent to child prevention of parent to child transmission?
Yes, sir.
So finally, we will move on to post-exposure prophylaxis. Pre-exposure prophylaxis is still not there under the national program. Okay, so pre-exposure prophylaxis, while it is being piloted, so under the NACP, pre-exposure prophylaxis is being piloted in certain areas. It is being piloted in red light area in West Bengal only. But still it has not come as a mandate under the National AIDS Control Program. However, post-exposure prophylaxis is very, very important. So post-exposure prophylaxis needs to be given to all at-risk exposures to body fluids. So since there are two determinants here, one is what kind of exposure it is, like we do in rabies, that what is the extent of the exposure, whether how invasive or how much of exposure has occurred, and the other determinant is what is the HIV status of the person to which the exposure had occurred. Okay, so there are two things that we need to consider here. The first thing is the exposure codes for post-exposure prophylaxis. Okay, so if the source material is blood, bloody fluid, or potentially infected material, okay, potentially infected material, it can be other body fluids, it can be a instrument that has been put inside the body of that individual. So if it is bloody fluid, or other potentially infected material, or an instrument contaminated with this surveillance substances, yes or no. Okay. So we have to look at the type of exposure. So if the exposure was only on the mucous membrane and the volume is very small, then it is given a exposure code of 1. If there is a large volume mucosal membrane exposure, then we give a exposure code of 2. If the exposure occurred on intact skin, then no PEP is required. If there was a percutaneous exposure, like a prick, if there was a prick that has occurred, and the prick has occurred by a solid needle and it is only a superficial scratch, then also we give a exposure code of 2. If the needle exposure has occurred by a hollow needle, maybe like a bone marrow puncture needle or a FNSC needle, and the injury is a deep injury. So if it's hollow bore or if it's a deep injury, then we treat it as a exposure code 3. So realize that mucous membrane exposures are never exposure code 3. So just like category 1, category 2, category 3 for rabies, we have exposure code 1, 2, and 3. If the exposure has occurred on intact skin, no PEP is required. If it has occurred on mucous membrane or on a cut or something like that, then if it's very small volume or for a short duration, then it's exposure code 1. If it's a large volume, major splash, or a long duration, it's exposure code 2. If it's a prick, which is a superficial prick or a solid needle prick, it's exposure code 2. If it's a hollow bore needle prick or a deep injury prick, it's a exposure code 3. So this is how we classify exposures. Next, we also look at the status of the source. Okay. So if the status of the source is unknown, that can be a case. Another case can be where the status of the source is known, the source is known HIV negative. So then no PEP is required. And if the status of the HIV case is known and that person is a HIV positive person. So if the person is HIV positive and that person, then we need to know what is the viral load status and CD4 count. So if they have a high CD4 count, they are asymptomatic, that is, they are not in the phase of AIDS, and they have a low viral load, that is, they have adequate viral suppression, then it is classified as a HIV source code 1. And if the person has a high titer of viral load, has advanced disease, that is, has overt AIDS, or has a low CD4 count, that is, has immunosuppression, then it is treated as a HIV source code. Okay. So we have 3 exposure codes, exposure code 1, 2, 3, and we have 2 source codes, source code 1 and source code 2. Based on this, we have this table of whether post-exposure prophylaxis is required or not. Now, if the HIV source code is 1, which is that the viral suppression is there, CD4 count is high, and the person is asymptomatic, and the exposure code is 1, that is only a very minor volume exposure for a short duration has occurred over mucous membrane or a breached skin, then PEP is not warranted. If the source code is 2, where viral load suppression is not there, or CD4 count is low, or the person is symptomatic, then even for a low duration or a low volume exposure on the mucous membrane, PEP is recommended for 28 days. Actually, for all other exposures. So for all other exposure codes and for all other source codes, other than when the person is HIV negative, duration, it is better to give PEP. Okay. So if you are considering the programmatic recommendation only with exposure code 1 and source code 1, PEP is not recommended. For all other exposure code and source code, PEP is recommended. Okay. So the PEP regimen, wherever indicated, is tenofovir 300 mg, lamivudine 300 mg, and efavirenz 600 mg once daily for 28 days. Okay. The first dose should be administered ideally within 2 hours. So if it is administered as early as possible within 2 hours, it is very good. Remember that HIV is a disease where if you are infected, you have to take lifelong treatment. So even if it is unknown, the program has to consider PEP, considering the prevalence of HIV in the population. It is always better to go along with PEP, go along with the pre-exposure prophylaxis to prevent the disease. And ideally, the first dose has to be taken within 2 hours to prevent the transmission of the disease or infection by the disease. The rest of the doses need to be taken at bedtime, and there should be advice to avoid fatty food during dinner. Okay. So that completes my